Good evening, everyone. I'd like to thank Alex first of all for inviting me to do this. I've done a number of lectures for him over the years, and we've got another one in September. And it's always good, and I'd like to welcome all of you here tonight. I'm not sure how I got talked into in video on this, but I've got my arm twisted. My mother said I had a perfect face for radio, but 3 days in May. And yeah, I like to sort of go into much of an introduction, as it were. As I get on over the years, I find I know less and less of the dentists coming through. So I'm not going to spend much time introducing myself, but just to do know, I graduated in Sydney, which is where Alex came from, and I worked in Canberra for a couple of years. Then I went to London to the Eastern Dental Institute, did a Masters in Restorative Dentistry there. Then I ran out of money, came back and went up to Port Hedland and worked up there for 3.5 years to get some more money. Then I went to the States, to the U of M, University of Michigan, and did some more cross training. And then I've been in Perth ever since, which is where my wife was from, since we ended up there rather than Sydney. So I have sort of moved around quite a bit prior to the last sort of 20 years when I settled here. And so, sometimes people say, oh, you get all these fancy cases and high flyers and all that, but that's not the case. That might make up 1% of my practice. And the other 99% are just sort of general average, Joe citizens that come in and they realise the value of sort of doing implant dentistry. So I don't get all high flyers, like I said, I wish I did. So also, I've been told we need to get out approximately about 8 o'clock. So I figure we'll have intermission at 8 o'clock, get out and then come back at 7:30. I've been known to have developed occasionally a case of verbal diarrhoea, so I sort of try and keep that in perspective. They're laughing already. So without further ado, so we don't lose too much time, we'll sort of get stuck into it. And what we're going to talk about is sort of immediate loading of singles, mostly single to large cases. We do single to large. In terms of the time frame, we're going to mostly talk about single to larges. Which reminds me, look, how many people here are carrying out implant dentistry? When I mean implant dentistry, I mean either placing them and or restoring them. So if I just have a show of hands, don't be shy. So yeah, it's maybe half. It makes it a little bit difficult because the people do implants are able to follow this and sort of different bend on. People who don't do it might get a little bit lost and try and get information of both types, both halves of the audience can be really difficult. Hopefully everyone gets something out of it. So what I'm talking about is a case like this where the central incisor is going to be extracted. This patient's got a high lip line, she's got almost an unrestored mouth. She actually works with SKG radiology, which you'll know the place. And the endodontist told me after 3 goes that too is coming out. The best chance you get trying to make this into an implant is your first chance. So there's a provisional there, slightly short out of occlusion. We're trying to maintain the soft tissues. There's the final restoration and the final implant. So we're going to talk about that quite a bit. There's another case there where the patient's going to lose this lateral incisor for sort of obvious reasons. And my problem is that she's got huge attachment loss on one side, not the other. It's sort of so asymmetrical. You think when you're going to lose that tooth, you're going to be looking at the bone, you're going to be in a lot of trouble. There's the final result. So there's almost more good luck than good management. And there's a sort of close-up of that. The other thing we're going to talk about for large cases where patients like this goes to become a patient like that. We're going to talk about the sort of so-called ball-on-floor restoration and sort of, there's not much doubt what that patient needs, the full clearance, and then the question is what do you do after that? Dentures, it's going to be over dentures, it's going to be, a fixed restoration. And that reminds me, can you all hear me down the back? Alex, you okay?
Yep.
Yeah? All right. So look at that, and we'll look at this type of case a little bit. This patient got extensive crown and bridge work, and these 2 abutments are failing, and so we're now going to implants, also some implants down there we're going to do. And we're going to go, here's your provisional, from that to that. And there's your ceramic final restoration, so all on 4. And these are all happen to be pro-series zirconia frameworks and build-ups, and those are the same. So the other thing is, like I said, not everyone here knows me. we run sort of implant courses, and I have done since 1999. I made up the name APEC. You hear that word in other areas as well. My thing is Australian Prosthodontic Education Centre, and we run implant courses sort of level 1, 2 and 3, or beginners, advanced, intermediate. We also run a study club, and most of these are strongly supported by Nova Biocare. Just so you understand, I don't work for Nova Biocare, I get paid for Nova Biocare. I use pretty much exclusively their components because I started with them, I grew up with them, and what I find, I'll talk about a bit more about that later, but I will mention some things twice. And I don't mind what system people use. You know, you can use BioRise, you can use Stroud, you can use 3i, you can use 10 others. You want to know that system well, and that's one of the take-home points. So I use the Nova Biocare because I find they've got the range of componentry and the backup that I need, if you like. So what we're going to talk about is immediate what I call placement, immediate loading, and immediate function. They're slightly different things. We're going to talk about that in relation to single, partial, and large cases. Okay? There's a difference between immediate placement, immediate loading, and immediate function. I'll just briefly explain that. We're going to talk about what is the difference, does it actually work, particularly people doing implants, why do we do it, what are the advantages of it, when can we do it, and for people doing it, when, we don't know how the hell we're going to achieve that. So the why, when, how, etc. Look, in my own practice, as far as immediate placement refers to just like as you're doing an immediate full-up denture, take the teeth out, the denture in straight away. So immediate placement refers to taking the tooth out, putting the implant in at the same time. If you took the tooth out last week or it was done 20 years ago, that's not immediate placement. You place the tooth at the same time. You could carry out immediate functional loading because you put the implant in and you load it with provisional restoration. That's separate. We'll come to that in a minute. And you know, in my practice, this is not a sort of a scientific study. This is me sitting down with, you know, a beer and my feet up, sort of saying how many cases I reckon I'll do with immediate placement. In other words, the tooth comes out, implant goes in, and I reckon about in anterior teeth, maybe 75% of those teeth being extracted and getting implanted at the same time. Okay? Premolars maybe 30% at most. Premolars maybe 1 or 2 rooted. If they're 2 rooted, then we won't put an implant in at the same time because we've got 2 roots, 2 sockets. It doesn't lend itself to that. And molars we pretty well never do immediate. I know some people do it more and more with the newer componentry. It's more amenable to do that. And there's a new website, a nice video that show that. And the other thing is that, which reminds me, I don't place implants. I don't do surgery. I've never placed an implant. I use a surgeon who was supposed to be here tonight. Can't see him. And so, as a prosthodontist, I know some prosthodontists do place their own implants. I like to restore them, I like to plan them. We're kind of in the middle, if you like. The patient sees us first. We can come up with all sorts of plans, send them to the surgeon, and we restore it. So I don't place implants ever. So when I have placed them as a demo for the students in like pig's heads and things, so I know how to do it, don't do it. The other thing is immediate function. In other words, when you put a provisional restoration, whether it be single, partial, or full arch, but we're talking about anterior at the moment, I'd say probably half of the anterior teeth that we put in, when you put the implant in, I'll get a provisional at the same time, like those couple you saw earlier. And usually out of occlusion, they're acrylic, they look pretty good, they look too good most of the time. And I'd say half the time they get that. This is the anteriors. Molars, we never do that. Premolars, maybe 1 in 5 might do that. Mostly because of cosmetic reasons. When we do the premolars, we tend to make the proceeding to almost look like a canine, so it's got very small palatal cusp and number. So the question is, why do we do it? What do you see? All right. Usually when you like to sit there in front, like that. So why do we do it? Look, I'm not going to go into tons and tons of detail. It's not necessarily sort of for tonight. I'm looking at sort of more of an overall picture. But basically, if you put an implant in, as soon as you take the tooth out, put a provisional on there, you don't have to have a removable prosthesis. The patient's really, that's the big selling point, for want of a better word. Because you only do one procedure, you have shorter treatment times because they're coming from one procedure. People talk about having reduced fees. My belief is they don't get reduced fees, even if the fees are increased. Reason being is you don't have provisional restorations that cost more than having a partial relined or what we call suspension bridge, etc. So I don't think they have reduced fees, they have increased fees. The patients certainly like it in terms of better acceptance. But the other big thing is you've got much better biologic response. Every time you raise a flap, do something with the tissues, the chance of more shrinkage, more scarring, more tissue loss in both hard and soft tissues. So doing that as a one-off and it's done has so many advantages that we do it wherever possible. You might see the slide before, where it's possible is maybe 70-75% of anteriors, 20% of premolars and molars never. But they're all the reasons we do it. The other reason we do it is market forces and the patients. Patients are really, like you hear patients saying, I read on the internet I can have teeth in a day or 2 days or 3 days, and my friend had it done a couple of days, in a couple of days. There's a real huge push now. Everyone wants things faster, and you know that. The other thing is, I think it's fair to say that the market forces, if you don't do it, the guy across the road will do it as immediate. So you've got to sort of be cognizant of that. Now, to do that, we have to know the difference between primary and secondary stability. Okay? Primary stability is basically a mechanical lock. When the implant goes in, it's like when I described to the patient, without trying to be funny, I talk about the screw for bunnings going into a piece of wood. It's how strong that screw is mechanically locked into the wood, i.e. how strong the implant is locked into the bone. Excuse me. With secondary stability, that's the biologic, so that's an instant. When you do primary stability, that primary stability occurs the nanosecond you put the implant in. With the secondary stability develops over time. 6, 12, 18 months if you like, 3 months, 6 months, it's ongoing. And it's a histological connection between the implant and the bone. Sorry, I've got to get, I'm talking all day. By the way, if you've got any questions, keep to yourself. So that's the mechanical interlock of the primary stability. We'll answer questions. It really depends on how dense the bone is, that makes sense, okay? It also depends on the implant design. What they mean, or what we mean by that is, to take the conical type implant, it's got to have almost like a wedging effect, and if you're doing immediate implant placement, immediate loading, immediate function, you really need a good implant design. So you don't want a parallel side implant, you want to take a conical type implant. And also it depends on the system, can develop on the surgical technique. And what we mean by that is you can under-prepare the cavity. So if, for instance, you've got a 4mm bone implant, you might prepare the cavity with 3.5 or 3.75. So when you put the implant in, it wedges itself in there, to have a short explanation of that. And that depends on the system you use and also the surgeon's ability. So with secondary stability, it basically, from a histological point of view, it's a direct link between the implant and the bone. And it's like normal bone healing, you can take up to 18 months to complete it. And that's not really quite true because in terms of 18, it's ongoing, it goes on forever. Now, this is if you sort of try and etch this graphic to your head, what we're doing here is measuring the stability or the mechanical lock, if you like, of the implant into the bone. And we've got here mechanical and biologic. Mechanical refers to the primary stability. What you see here is, there's where the implant's placed. The primary stability goes down, 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 down with time. As that's going down, the histologic stability goes up, up, up. So this is the secondary stability or biologic stability. This red line means that you've mucked up the surgery, you've got the wrong design, just ignore that. So what happens is you see there's a huge drop here, sort of 1, 2 weeks, 3 weeks, as it goes down. At that stage, the biologic stability, if you like, hasn't gone up yet. So what that means is that if you're going to do immediate functional immediate loading, the guidelines say you want to put this in the first week or 2, so it's where it's up there, or you wait 8 to 10 or 12 weeks where this secondary stability comes up there, see? So you either put in early or you wait and put in late. That's This is why I do it. This graph's got I've seen it. The other thing is, look, if you have a look, this is this sort of concept of immediate stability or immediate place, immediate function, all started to mushroom 10, 15 years ago. Prior to that, everything was sort of more a delay, put the implant in, wait, do a second stage, wait, put it in provisional, wait, etc. So what happened about 10, 15 years ago is you have a look at this journal, this sort of big hitter at 60% of the articles are on immediate function, okay? But, and like I said, I'm not a no care person, don't pay me, I wish I did. But basically, what you have to look at then, it's probably even more applicable now, is 60% or thereabouts of the research and the articles that come from no care. So they've been, I think it's fair to say, the leaders, and they've got the biggest push into carrying out this type of treatment. They've also got the componentry. If you have a look at ITI Australia, go at 10, and the rest for another 10. So it's not sort of all systems are created equal. That's just a fact. That's how to disguise data. The other thing is we get to sort of modern times, and who here uses Straumann? Don't be shy. Okay. Well, I went to a more recent sort of presentation. This gentleman here, Axel Sparr, sort of one of the big hitters here over in Sydney, and he was here for a lecture, and he talked about teeth versus implants and perioregeneration. He made no bones about the fact that he was a Straumann person. Okay, and well, so I call him a straw man basically. But videos are made. You recording this? He said a couple of interesting things. One is that he always does a two-stage surgery. This is the direct quote when I went to his lecture. So he always does a two-stage surgery, which is pretty amazing in this day and age. He doesn't use the tissue-level implants anymore. He uses wide platform. He said wide platform implants result in bone loss. This sort of three of his catchphrases, the three that caught my attention. Now, if you want to do, they had a consensus meeting again 10, 12 years ago in Spain, and they came up with some occlusal guidelines. You can't just go and do willy-nilly immediate placement, immediate loading, immediate function, expect to get the same results. We can meet those guidelines in, like say, 70% of the time, 50% of the time, etc. Some of these guidelines are, you've got to control the occlusion, okay? If you're doing larger cases, you've got to have enough implants to spread them out. You can't have large cantilevers. You can have cantilevers, but not at the start. So when we do full arches, we virtually do the provisionals that will never have cantilevers, or very small cantilevers. We put longer, sort of extended cantilevers after, like 6 months down the track. They talk about non-occlusal loads. So what they're trying to do is, you don't have the teeth in occlusion and centric occlusion, you may have an excursive movement. So it depends on the occlusal scheme whether you can actually achieve that. They're in what we call function rather than load. Function means that the patient can function if they can smile, they can talk, they can go down in terms of not overloading the implants. When they've got occlusal contact, that's called loading. When they've got no occlusal contact, that's called function. And that's the sort of definitions of it. They talk about reducing cantilevers, like that's a real biggie, which I've got a section on after the end, last slide, and I left it out. It's still up there because of the time constraints, so if I can, I'd like to show that. And again, maximise the spread of contact. The other big thing is get the patient back after a few days or a week and recheck the occlusion. So make sure that it's out of occlusion, it's evenly spread, etc. It's very important. There's a number of places where you can't do it, or it's contraindicated to do it. Okay? They're medically compromised, or they're smokers, they've got poor oral hygiene, poor bone. We don't do it. Short implants, now what people consider short implants